3 cancer diagnoses for one woman starts with a single spot on her face. Coming up on today's Morning Medical Update, a rare discovery during a routine screening highlights the importance of keeping your annual checkups. And good morning. It is Monday, November 28th. I'm Jessica Lovell. Welcome into the Morning Medical Update. We are live inside the Dolph C. Simons Jr. Family Broadcast Studio today. Alice Marshall had a spot on her face that turned out to be lymphoma. She was diagnosed in 2015 and immediately started chemotherapy, followed by a CT scan. That scan changed everything. It detected stage 4 colon cancer and sent Alice into an epic battle to save her life. We're going to learn a lot from Alice, who hopes that you will be inspired to set up next year's health screenings today. So send in your questions on YouTube, Facebook, and the Medical News Network. You can find links to those right there on your screen. Before we introduce you to Alice, here's a little bit more about her story. It began with her daughter, who encouraged her to get a spot on her forehead checked out. Now, the spot turned out to be a rare lymphoma, and doctors in Topeka referred her here to the University of Kansas Cancer Center. It's there that her oncologist ordered radiation and a CT scan. The scan then revealed stage 4 cancer tumors in her colon, one of them the size of a golf ball. As you hear the details of her remarkable story, we know that you may have questions and you'll want to learn more information on treatments and screenings, and you can find that by clicking on the QR code here on your screen. Alice now lives in Olathe, and she joins us this morning from her home. So good morning, Alice. Good to see you.
Good morning.
Hello. We'll get to you in just a moment. Just want to introduce 2 of her oncologists, Dr. Raed Al-Rajabi, right here in the middle with me, and the director of the Regional Cancer Therapies in Surgery, Dr. Mazen Al-Kaspouls. Gentlemen, thank you for being with us.
Thank you for having us.
Always good to see you. So, Alice, this all started with that spot on your face, but before you were done, you would endure radiation, chemo, multiple surgeries. That was 6 years ago. So tell us, get us updated. How are you doing today?
I'm doing great. I'm extremely grateful for all the care that I've had. The team is amazing. I've got an incredible medical team.
So again, 6 years ago, you went through your treatment and you're back. Do you feel back to Alice? Tell us a little bit more about what's going on in your life and how you're using your story to help teach others and give them that power to put their health first.
Well, I'm a colorectal cancer ambassador for the Fight Colorectal Cancer organization, and I do the pivot meetings that go through the University of Kansas. That's for patient and investigator voices organizing together. That has been real good. I take part in Climb for a Cure, which is that picture there, to raise funds for the Fight Colorectal Cancer organization.
So to say this has changed your life drastically in good ways. It used to be bad ways, and now it's really good ways.
Right. Yeah, I try to spread awareness because I figure the more people know, then more people will get screened, and hopefully it can extend their lives.
So, Dr. Al-Rajabi, do you usually use CT scans to look for colon cancer? Why was that CT scan scheduled?
So I think that CT scan was scheduled because of the spot on her face. Usually, most cases in this situation are diagnosed by colonoscopy, and it's usually a screening colonoscopy. A lot of times cancers are not this advanced and would not be detected by just CT scan alone. We definitely consider CT scan once you have a diagnosis of cancer to evaluate the extent of spread.
So, Alice, you had a colonoscopy before all of this. You had no signs of cancer. So how long before you were diagnosed?
Well, I had my colonoscopy when I was 50, and then what Dr. Yakub asked when he saw the CT results, he asked when I had my last colonoscopy, and I said when I was 50. So he said, well, you'll have another one before you're 60. And I was 59 at that time, so I was pretty close to 60, but that's how it happened.
So again, she was doing everything right, getting those colonoscopies, something a lot of people don't hurry out and go get, but she was doing it. And that was a good thing. We're going to talk a lot about that because you said you had one at 50. Some of those, the ages have changed for that. So we're going to talk about that in just a moment. But Dr. Al-Kaspools, Dr. Al-Rajabi sent Alice over to you, and then you break the news that you need to remove more than a foot. Is that right, of her colon?
Yes.
Did that foot, was that all cancerous, and that's why you had to take so much?
Oh, no. It's because, well, the reason you remove a foot is because during surgery, you have to not just remove the colon, the part of the colon that has the cancer, but also the lymph nodes as well, because the lymph nodes, which are taken as one piece of tissue, will tell us what stage she is. At the time, we didn't know she was stage 4. At that time, the surgery not only took care of the cancer, it was not just therapeutic, meaning, but also it allowed us to stage the tumor, meaning determining whether it's stage 1, 2, or 3. Again, we didn't have any suspicion that it was stage 4 at the time. And it was done minimally invasive, so it was less trauma to her body, which makes a difference with her recovery. But she did really well with the surgery.
So help us understand, though, when we hear stage 4, I think our minds all go to the same place. But what is stage 4 when it comes to colon cancer specifically, as far as the type of treatment and how quickly you have to move?
I'll let Dr. Al-Rajabi answer, but it just it means that it's gone beyond the organ and, in general, the lymph nodes that surround the organ. It has spread beyond that. I'll let Dr. Al-Rajabi.
I think Alice, when she first was diagnosed, she had a suspicious pulmonary nodule. We weren't sure what it was, but it was kind of concerning. And when you have stage 4 colon cancer, the likelihood of cure goes down significantly. But in some lucky cases, if you follow it very closely and find that there are only 1 or 2 spots, or maybe or a very small frequency of spots of spread, you could potentially consider more surgeries to achieve a cure.
So it gives you that more time. So you said she was one of those lucky cases.
Yes.
It was her getting those colonoscopies. I mean, why wouldn't that have been caught sooner? So was there something happening between when she got hers and when she would then go on to have that second colonoscopy when she was 60?
So when you have a normal colonoscopy, the standard of care is to repeat your colonoscopy in 5 to 10 years.
Right.
And unfortunately, there are some cases that do occur in the meantime. Of course, if Alice had really concerning symptoms or signs, maybe precancerous polyps, we might have had to do the colonoscopy a little bit earlier after her first one. But unfortunately, some cases do occur in those years.
So, Dr. Al-Kaspools, Alice started chemotherapy, but then she wasn't able to finish it. Is that what I understand? Why would that be?
Yeah. So at the time when the colon was part of the colon was removed, her lymph nodes were positive. Again, we weren't 100% sure about the lungs, but we knew that she at least had stage 3 cancer at the time. So she went on to receive chemotherapy, but she didn't get all of her treatments, right?
That's correct.
Yeah,
that's correct. She had a really difficult time. A lot of times patients can't tolerate all of the chemotherapy, but that's still okay. You're still getting some benefit from the chemotherapy. And Alice had a really rough time where she lost a lot of weight at the end. She had a lot of toxicities to the chemotherapy. Our goal is, of course, to wipe out the cancer, but also to ensure that we don't have any permanent disabilities or problems in the future.
So, Alice, the hits kept coming for you. Cancer was found next in your lungs. How was that discovered? Tell us about that, and then how you were holding up at that point.
Well, the spot that Dr. Al-Rajabi was talking about, it was like 0.4 centimeters. And then 10 months after I finished chemo, it grew to 0.9 centimeters. So that's when they decided to send me to Dr. Garamachanini, and he removed the top lobe of my left lung. And then I chose to do chemo again. I didn't have to do chemo again, but I thought if it's swimming around inside of me, then I want to get rid of it just in case. So I figured it was safer to go ahead and do chemo again. So it was a different dose because it was pretty severe that first time, but I did 12 rounds of chemo. So in a total, I did 20 rounds of chemo, counting the first ones and then doing it again the second time.
Okay, so is the lung cancer a result of the colon cancer, the stage 4, or are those two separate?
That is correct. So it's the
talk us
same.
through that.
It's the same tissue.
Okay.
Cancer basically stops listening to the body and starts spreading to other organs through the bloodstream and other methods, and unfortunately just doesn't shut down. And so it is colon tissue inside the lung, not lung cancer or a different cancer. It's her original tumor that had spread to the lung.
So is this rare, what we see in Alice's case, where she's healthy, she's getting her screenings, ends up with stage 4 cancer? Would this mean that is it fair to say she had a family history, or could there be no connection regarding that?
I think Alice overall did not have a major family history. We also considered genetic testing on her after her diagnosis, and that really was negative. It's 50 after the age of 50 is when you see most patients with colon cancer, but unfortunately we're definitely seeing a higher incidence in younger and younger folks going forward.
Important conversation. We want to talk about the recommended age to start screening. It's 45. I will say right here, Dr. Hawkinson and we had our colonoscopies this year.
Yeah.
Not
Absolutely.
together, but we had them, and we were really proud that we did it, right?
Yes,
And
absolutely.
well, we had to walk the walk because we talk about it so much, the importance of screenings, and I was late to the game getting mine, so I had to make sure I did it. And then you went, and so everyone's in the clear. But 45, American Cancer Society found that people born in 1990 or later have double the risk of colon cancer and quadruple the risk of rectal cancer compared to people born around 1950. Okay, of course, that question is why? Why might that be? Do you have? I want to hear from both of you.
Yeah, we don't know why. We don't know why it's happening. It's not. We know it's not just genetic because that's less than one generation. I mean, just basically one generation, and genetics can't change that much. So something in the environment is causing it, and there's a lot of research happening right now to determine why we're seeing it so often in younger people.
Doc, your thoughts?
I agree with Maz. I think we really just don't know. Some people have speculated it's related to our increasing weight, our society's more obese, that increases the risk of cancer, but honestly there's really no direct correlation of why this is happening to our younger generation.
Somewhat of a mystery.
Yeah.
We think maybe decades from now we'll be able to maybe closer pinpoint what it is.
Oh, yeah.
Most
But
of
in the meantime, that's why the screenings,
Yes.
they matter. So in what world would someone need to get one before 45, or do they not need to?
So I think if you have a family member that's been diagnosed with colon cancer or rectal cancer, you should most likely have a colonoscopy 10 years before your first-degree relative was diagnosed. Having a first-degree relative with colon cancer automatically increases your risk of cancer, even if there wasn't a inherited mutation or a inherited syndrome that could increase your risk. Any patient that has symptoms like altered bowel habits, blood in the stool that are persistent, that means it's not a one-time deal, really should get checked out by their primary care physician. Other symptoms include abdominal pain, unintentional weight loss, severe fatigue that persists.
Make sure you're recognizing those symptoms and then communicating it with your physician.
That's correct.
So I get mine when I'm 45. Now, so I was 47 when I got mine. I was 2 years past. So when will I get my next one? Do I wait 5 years?
It depends
Or
on
10?
it depends on the guidelines.
Okay.
If you have family history,
Don't have family history.
So, and if you had no polyps,
Nope.
then it's 5 to 10 years.
So does that
at
mean
your
it's a
discretion.
slow-growing cancer? Is that why?
Yeah, well, polyps tend to take, and there have been preclinical studies that looked at this, tend to take up to 10 years to turn into cancer. That's
Okay.
why we've spaced out colonoscopies to 10 years. But patients that have inherited risk or mutations that they've acquired from their first-degree relatives could potentially develop cancer much quicker than that.
So that's why you get the screening to see if you have the polyps, and then your doctor would recommend what's next.
Yeah, I think that's an important point that he made. Most people, when they're diagnosed with cancer, we believe it's been there for 5 to 10 years, but it takes that long before it becomes before you can see it, that you can spot it on film, on either colonoscopy or on CT scan. But again, it's usually found on colonoscopy. Yeah, I think there's a misunderstanding that most cancers don't divide quickly. They just don't stop dividing, you see. So normal tissue, when you lose a cell, it's replaced, but then it stops dividing after that. But in cancer, it just continues to divide. Not faster, it's just not controlled, is the difference.
Okay.
It doesn't stop. There's no stop to it. That's the issue.
Okay. Okay, you mentioned signs. Anything else we should know before? I want to ask Alice about her meeting with Governor Laura Kelly here in just a moment. Any other signs you want people to know about, though? Any reason they should call their doctor? This is a time when we're running into our families and sitting around dinner tables. Should they be asking about these kinds of things and asking about history of grandparents or?
I mean, I think that's important. I think the point that I think that Dr. Al-Rajabi made, and it has to be really remembered, is that when you're younger, you don't think you can get cancer, and for a long time, that as doctors, we believe that we don't see it in young people, so they shouldn't worry about a little bit of blood and a little bit of constipation, But you have to really know your body, and I think if you're younger, don't just assume it's not cancer. That's the key. Go see your primary care doctor, just like Dr. Al-Rajabi said. It's really critical that you don't blow these things off anymore.
And that's what I like, is that as we learn more, we're now changing. We're allowing those guidelines to be more fluid, and they change back, and so I think that's really important. Alice, I want to ask you about this special meeting that you had with Kansas Governor Laura Kelly. Tell us about it and what the result was.
Okay, that's with 2 other colorectal cancer ambassadors. And we met with her, we sent in the request, and then we met with her because March is the awareness month for colorectal cancer. And she signed the proclamation making March noticed for the colorectal cancer awareness month.
For the state of Kansas?
Yes,
Fantastic.
They're trying to get somebody from each state to do that. So Kansas was taken care of.
And we thank you. How has it been, though, for you to have this support group that you've had, to now be involved in these groups that you never thought you'd be involved in, sitting there signing a proclamation with the governor of Kansas? Must be rewarding in so many ways.
It does, and it feels good also to be together with the other people that have gone through this. It's kind of nice to hear their stories, and it's just a support system that it's nice to be able to talk to others that have gone through this.
Fantastic. Great work. Dr. Hawkinson, let's check in with you, Medical Director of Infection Prevention and Control. We've got to get to our COVID numbers coming out of the holiday weekend. Good morning to you. What do we got?
Hi. So right now, 23 active cases in the hospital, 2 in the ICU, 1 on the ventilator, 15 in that recovery period. And again, if you look at the CDC data detailing cases, and it now is going week by week rather than day by day, you can see that the last couple weeks, the number of cases have increased. Hospitalizations overall in the nation look to be about stable. But again, we also know that hospitalizations tend to follow new cases by 2, 3, 4 weeks. So.
Okay, question for you. Monoclonal antibodies may no longer be a match for emerging COVID strains. This could be a big loss for treating immunocompromised patients, I would imagine. So Doc Hawk, just kind of talk us through this.
Yeah, absolutely. So the monoclonal antibodies, again, which were released quite early in the pandemic as treatment. Later on, there was a monoclonal antibody, a combination of 2, which were released as a preventive measure for those people that either couldn't get the vaccine or probably would have a poor response to the vaccine, and that was Evusheld. Both of those really act in the same manner as the treatment monoclonal antibodies, of which there's been 3 or 4 or 5, but bebtelovimab was the most recent one that we've been using for quite some time. But then there also is that preventive method of Evusheld, which is a combination of 2 monoclonals, and they tend to bind the spike protein so that you can help prevent and stop infection of that virus with a local cell. Unfortunately, as what we have seen with the Omicron subvariants, as we have now gotten further out from the original Omicron, is that these subvariants are resistant to those monoclonal antibodies. So those monoclonal antibodies either don't bind as well, or even if they do bind, they don't block the infection and the fusion to the cell. This is quite concerning, especially, again, for those people who are immune compromised, who can't get the vaccine. We are continuing to watch. We are right now in discussions about stopping the treatment with the monoclonal antibody and possibly Evusheld. If you look at the latest recorded data for the CDC, it shows that about 50% of the isolates that they've obtained are BA.5 and the rest are the variants. If you look at the forecasted, which is the nowcast, which I think has data up till the 26th, but again, that is a forecast, you'll see that the variants, a couple of them in particular, do overtake BA.5, and BA.5 is then about 20%. So the rest of the circulating variants in the United States really seem to be things other than the BA.5. These are the variants that are really not treated or are resistant to those monoclonal antibodies. So it is certainly a concern. We still do have activity of Paxlovid, which is the oral antiviral, and also remdesivir as well. So we can use those, but certainly for a large subpopulation of the United States and people around the world, the inability to use these monoclonal antibodies is certainly significant. Hopefully, there will be new monoclonal antibodies coming down the pike as well.
Any reporters with us today? Let's get to community questions. Dr. Hawkins, and I'm going to stay with you. Yeah. Joella wants to know, do you expect a COVID surge due to the holiday gatherings this past week?
Yeah, I mean, I don't know that it's specifically with the holiday gatherings. Certainly, I know I traveled. There were very few people in masks. I was wearing a mask still. But we know overall that we have been concerned about an increase basically because of the changing weather as far as colder temperatures, people doing things indoors, but it's certainly people gathering together will cause increase in cases as well. Just how much it remains to be seen. And again, always looking at those hospitalization numbers. That's why it continues to be so important to get tested early. And if you do meet that criteria for having Paxlovid, get on Paxlovid early to help reduce your risk of hospitalization.
Vicki wants to know if you have any comment on the Kaiser study saying that deaths are now dominated by people who are vaccinated.
I don't. I know that we have talked about that in general, is that, you know, we would wish that everybody in the hospital would be vaccinated because that means, number one, overall, the numbers are probably much lower than they were before, but also two, that we can get those vaccines into arms. So I don't think that is surprising. I would like to see the data. What is that data showing? Are those people just vaccinated with the primary series? Are they up to date with their booster? But also, what other kind of comorbid conditions can we see? Because we know, certainly for our experience here at the health system, the vast majority of the people that have come into the hospital and have died, number one, have not been vaccinated or have not been up to date with vaccines. And even if they have been up to date with vaccines, they had some serious comorbidities, including age, immunosuppression, and other organs that weren't functioning properly even before COVID-19.
Ruth Ellen wants to know, are there any studies that you know of on individuals who have not yet ever tested positive for COVID? I guess we know you could be positive and not have tested, but any insight on that? Like, I know people think they're like have some special magic power, but what do we know about those who've just never?
Yeah, we know that there are studies ongoing to look at those people who may have not been infected yet. The other thing is we know that there was a large proportion of asymptomatic infection. So it's really trying to understand, have you ever been infected? Certainly we can do that with antibody tests. But then also, you know, really what the major line of thinking is that if you haven't gotten it, you're just lucky. But they are trying, I did see a research study that they are trying to look at people who have never had evidence of infection. But you really need to get down and dig into those details about what has your exposure been, you know, have you had other people around you that have been affected that you haven't? So it gets kind of dicey at that point in time. But I do know that there is one or two studies that are going on trying to look at those people and reasons as to why they have not been infected, especially if they've been in some of those high-risk situations.
Have a couple of questions, actually one for each of our guests today. And Alice, I'm going to ask you. Bennett wants to know, well, we'd already talked about that, how often you have gotten a colonoscopy and then when you'll get another one. But are you on any other medication? And has your lifestyle had to change at all because of the colon, part of the colon being removed?
No, I'm not on any treatments at all for cancer. I do exercises every day, and I also swim laps. I like to swim, so those are good exercises. I didn't have any family history. My husband's parents both died of colon cancer, but he's always been clear. So it's weird how when I found out I had colon cancer, he said, well, it's not supposed to be you, it's supposed to be me. But I said, well, surprise. And they said 14% chance of survival of stage 4, but I figured somebody has to be in that 14%. So why not me?
Why not me? I love that. Laura wants to know, Dr. Alkaz-Poulos, what, back to having that colon removed, does that leave somebody with side effects normally, where they have to have a diet change, they have to live life a little differently? As Alice, she seems kind of like a special patient, as we're learning, but what would be maybe a typical scenario?
Yeah, it's a great question. In general, unless you remove a lot of the colon, the number of bowel movements may change a little bit every week. You may have a few more than you're used to. Once you start taking more than half of the colon, then you start maybe having some symptoms like that. In removing a foot or even a little bit more than a foot, that's no more than about 20 to 25%.
I was just going to ask you, how many feet are in there?
Yeah, well, it's not by feet. Everyone's got, it's about percentages really.
Okay.
Because a big person's colon is going to be, larger than a small person's colon.
Right.
Yeah, it's really about their body, but really it's the percentage that matters the most. Yeah.
Roger has a question, and I think this is really important because we use the term a lot, no evidence of disease. We often don't use the term cured, or even sometimes we use remission, but there's kind of that gray area of what it really means and what we want to make sure that we're being clear about. Can you kind of help us understand what that is when it comes to somebody who had stage 4 colon cancer? And is somebody, I don't know, we don't use the word cured, correct?
That is correct. Roger is correct. We use the word no evidence of disease. Patients like Alice are monitored very closely for the first couple of years, and then basically that can be spaced out. We use several things to monitor patients with colon cancer. Now we have some newer technologies that weren't available, but we use them. Like CT scans, and now things like circulating tumor DNA, and that's detecting microscopic levels of cancer DNA in your blood. That could indicate a higher risk of recurrence. So there's a lot of technologies, a lot of clinical trials that we're doing at KU that would potentially benefit patients.
So is no evidence of disease and remission one of the same? Or are we still better of saying no evidence of disease at this moment based on the tests that we have available today?
Yeah, I think in solid tumors we say no evidence of disease. Unfortunately, we don't have cure rates as high as liquid tumors or blood cancers, where cure rates are much higher and you could say you're in remission.
Gotcha.
But I usually say cure in a patient of colon cancer or solid tumor after 5 years.
After 5 years, you can use that C word, the good C word, right?
Yes, the good C word.
Okay, I want to get final thoughts, and I want to start with you, Alice. And before you do, Cindy had a question. She says, I think I would be in a puddle on the floor if I was ever diagnosed with cancer. I don't think you always know how strong you can really be until after you're diagnosed. You think you're not going to handle it, and then you turn to your family and your friends and the community, and you get your way and you get yourself through. But she's just asking, before you get to your final thoughts, just kind of, what really, when you opened your eyes every day and stepped out into the world, what got you through day to day to day?
Well, faith is important. My family is very supportive of me and everything. So I always say faith and science, those two work together. We have them both, that with the research going on and stuff, that's why I'm still here. That's what I feel like, faith and science.
And you wear that And you wear
my
that
children-
relentless survivor shirt very, very well.
Thanks.
I love
That's
that.
from the Colorectal Cancer Organization.
Tell us just your final thoughts. What do you want anyone who might be, I think we really love the idea of screening and preventative medicine where we can get to it before it's too late. So tell us what you want folks to know. You know, we're coming to the end of the year and people are going to start thinking about their 2023 screenings, and what's your message?
Well, anytime you see something that's unusual, that no matter where or what it is, like your skin even, be sure to get it checked. If it's questionable, then it doesn't hurt to get checked. It's better to get it sooner than later. So if you see something unusual, then go to your doctor and get screened.
And do what your daughter did, which is she noticed something and pushed you to get, and something as simple as, it's easy to think of something on your skin, something that you can blow off, but it led you to other diagnoses that then turned into, had you not have caught them, they could have been deadly. So we're so glad for that, grateful to, you know, look at your body, know other, you know, look out after your friends and colleagues and family members. So I appreciate all of that. And so good to see you, by the way, finally good to meet you.
It's good to be here.
Well, stay in touch, okay?
Okay, thank you.
Keep fighting and spreading the word. Dr. Alcas, your final thoughts today. Just what do you want folks to know?
Yeah, you know, these are interesting times. I think from a surgeon's perspective, you know, where it used to be that we didn't operate on patients with stage 4 cancers, and it's just until recently, and it's really because of not only modern technology, but also modern medicine in the sense that we have better chemotherapy now. So because of that, we're actually asked to operate more aggressively in patients with stage 4 cancer, and that was unheard of, you know, 15 or maybe 20 years ago, you know, when I was still in training.
Right.
We'd never do that, but nowadays we do, which is interesting in the sense that we have better chemo. You think you wouldn't need more surgery, but it's actually not necessarily true. We are more aggressive surgically because it works better.
And because you can.
Yeah.
And so it must be really rewarding to
Yes,
sit here and be able to have conversations with patients like Alice and know that she was one of those people that that technology worked on.
Yes.
Okay, Dr. Al-Rajabi, your final thoughts today as we head out into a new week.
I think if you're not feeling good, be your own advocate. Even if you've seen your doctor and things have not gotten better, always go back and see your doctor. So it's very important. I think when dealing with a cancer diagnosis, it's always a good idea to see what options you have in the community from research and really cutting edge technology. And I think always looking at your options is important because it opens up more doors and possibilities, especially in cases of stage 4 colon cancer. You know, there may be other options that are not available locally that people can investigate. And fortunately, us becoming a comprehensive cancer center recently indicates our commitment to research and developing technologies that will help save lives and hopefully have great outcomes like Alice. I know she did all of the work and she was a fighter, but helping achieve that goal is our mission here at KU.
Yeah, being a great patient helps, doesn't it?
Yes.
Okay, we'll have different experts on tomorrow, and since I have you two here, I do have a couple questions I want to get in for a couple of our viewers. And Yen Liang wants to know if you could explain that connection between that spot on her face and lymphoma and then the colon cancer. Again, are they separate incidences? Is it one thing led to another? Was it just a lucky thing that happened? The spot led to something else?
It was coincidental.
Coincidental.
Yeah, they didn't have any relation.
Any relation? Okay. And then do you think that aspartame or other artificial sweeteners could be linked to the increase of people? I mean, you know, all the weird things we're putting in our body these days, who knows? I guess we'll find out decades from now. But any insight, thoughts?
I mean, it could be anything. I mean, it could be a virus, too. I mean, there are associations between viruses and cancer. We know that. So I think it's up in the air. And obesity, that's a good point. Obesity could play a role, I guess, but I see it in skinny people all the time.
Sure.
Skinny young people all the time. So.
And skinny young people eat junk all the time too, and processed foods and fast foods. So it pays to really be thinking of what you're putting in your body and keeping your body active.
Yeah.
Okay. Thank you for answering the questions for our viewers today. And Dr. Hawkinson, final thoughts from you.
Yeah, really good questions from the viewers today on every topic. This topic, again, continues to bring in one of the biggest topics that we continue to endorse, and we've heard it here. It's about screening and prevention, and we heard our guests even say that. That is the best method moving forward to help keep you safe and healthy. Identify anything early and get it treated early. That's with all of the screenings and, of course, the prevention with the vaccinations. And there are a lot of vaccine preventable diseases that we should all be getting and be up to date with our vaccines. Please talk with your healthcare providers or your pharmacists to help figure out which ones are best for you.
Great message. Thank you all so much for being with us today. You can catch our updates anytime by logging back onto Facebook, YouTube, and Twitter. We will see you back here at 8 o'clock tomorrow. Coming up tomorrow on the Morning Medical Update, Jay Leno suffers third-degree burns and doctors prescribe treatment in a hyperbaric chamber. I'm Jessica Lovell. Join us on Tuesday as we take you behind the scenes to our hyperbaric chamber to explain this medicine. Plus, our burn specialists explain the top 3 burn dangers during the holidays.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcast. Now, everywhere podcasts are available.